Test. Okay.
Mic down, and I was like, "Oh, that's a cool move." I'm gonna stay stationary.
Okay.
So this is on.
Oh, it's just mute.
Okay. All right, and I've got to. I'll keep us on time.
And we want to make sure. Hello. Here we go.
Kicking up the days always the time. You're in the first slot and they might have. No, I know. I just started the recording. Okay.
All right. Hi, everyone. Can everyone hear me okay? Good morning. All right. It is time to begin this exciting session. We have 3 panels that are going to present for you, or 3 separate teams. They'll be sharing their presentations. I'm Molly Lawrence, she, her. I'm a supervisor for community health strategy and impact with UVM Health Network. And so glad to see so many familiar faces and new faces here today. We are going to get started with Do No Harm, mitigating the harm from community engagement in rural communities. And I'm going to let each of our presenters introduce themselves. And we have a full session here, so we'll get right into it. So Sally and Renee, I'll turn it over to you. Thanks so much.
Great. Thank you. Good morning, everyone. I'm Dr. Sally Kraft. I'm the Population Health Officer at Dartmouth Health, and I'll let Renee introduce herself.
Hi, everybody. My name is Renee Pepin. I'm an assistant professor in community and family medicine at Dartmouth Health.
Great. So we're really excited today to get started with, I made a switch. Ooh, that was smooth. We're going to get started with a real life situation. We want you to do a little bit of role playing. So here's the scenario. You are, each of you are an executive director of your rural food pantry. It's 3 p.m. on a Thursday. You serve a town of 4,000 people. And in the surrounding area, and you have 3 part-time staff, but one of them just let you know that they're going to be leaving, but you have till the end of the month. All right, here we go. You're getting ready to prepare a grant proposal. It's due very soon. And you want to buy a new refrigerator so you can improve the amount of fresh produce that you're distributing along with the shelf-stable foods. You have 2 hours to work on this proposal. Everyone get ready with your phones and your, I'm not going to keep you here 2 hours, but get ready with your phones and your pen and paper. And you are really, you really need this money for this refrigerator. I would like you right now to write the first sentence of your proposal. I want you to knock this out of the park. I want this to be compelling, to grab that funder by the heart. And you're going to open up your grant proposal with just like, call me Ishmael kind of sentence, right? So everyone get ready and start.
You're going to have a full minute for this.
Oh, wait, sorry, excuse me. I'm Dr. Kraft, actually, and I have this super cool idea that we're going to set up a pop-up clinic right here in your food pantry. We're going to bring in all sorts of social services and some clinical services. And I'd like to talk to you about that. You might be busy right now, but I would like to talk to you about that. So go ahead and keep working, but I'm going to come back to talk about that.
Hello, I have a request. I'm a researcher and I have the perfect grant proposal. It is right up your alley. It's really centered in aging and nutrition. And I have a deadline. I need to submit a letter of intent by the end of the day tomorrow. This is really in line with things that we've talked about before. I'm sure we have your approval, but you do need to sign a letter of intent. You need to get the executive director and the board to sign it. But I'm sure we can make that happen by tomorrow. I have a template for you. Don't worry about it.
Oh, I'm the assistant dean of the community college down the road. We have a nursing program. Our nursing students just heard about community engagement and they really, really want to come in and they would like to spend some time with you and learn about your community-based organization and all the good work that you do. And we need to get your approval right now.
Okay, so that actually wasn't a minute. It was 2 minutes. So how do you feel? How do you feel about your proposal opening statement? And how do you feel about your ability to facilitate those requests? Thumbs down. Relatable, right? These are things that happen for community-based organizations all the time. And that's really what has brought us to this work. So I assume that we're preaching to the choir a little bit, that the people in this room are actually like really interested in outreach and community engagement. But to get us on the same page, I'm going to provide a definition, which you can see on the screen. Community engagement is engage the community to achieve long-term and sustainable outcomes, processes, relationships, discourse, decision-making, or implementation. And this is from the Penn State Community Engagement Toolkit, which is one of about 1 million different toolkits that help us think about how we might do community engagement. It's really overwhelming, all the different frameworks and toolkits that are out there. We've been really interested in, before we think about the skills related to community engagement or alongside the skills related to community engagement, thinking about some core domains or competencies that are really important for people to consider while working on community engagement. So the first would be engagement. Some things that are key here are curiosity, right? Interest in multiple different solutions, regardless of who's bringing them to the table, the ability and the tolerance for sharing power, humility, being able to hear that our solution isn't right, that we're wrong, that we've hurt people. Communication skills are really, really important. Paramount is listening, which people are not really taught to do. We need to be thinking about different levels of literacy and comprehension. What we're really going to talk about today is ethics, so I'm going to come back to that. And then process improvement, this idea that we are trying to improve things all the time, that we come up with a solution, and if we come up with a solution in partnership, we're going to let something happen, and then we're going to take all kinds of input about how to improve that, put it back out, right? This iterative improvement. And ethics. So we're interested today in talking about minimizing harm, but really we're thinking about respect, justice, and autonomy, like regular research ethics. But community engagement really calls us to think about this balance of who's benefiting and who's incurring risks. How many people try to get funding? Yeah. So great. Has anybody noticed funders sort of expecting or demanding community engagement? Yeah. Yeah. So we're definitely seeing across the board in research, foundations, and even philanthropy, this increased demand and expectation for community engagement, which is great. And it creates problems because there's this proliferation of people trying to engage the community who may or may not have the skills, the relationships to do that, and might continue to go to the same community members or the same organizations over and over and over again and ask them for a community service learning project, ask them for a letter of support for a research project, ask them for help with some hospital initiative. So what we're really grappling with, and like, I don't think anybody has the answer, right, is How do we engage community in an ethical way? How do we minimize harm within the community? How do we maximize benefit to the community? And really, what's going to happen if we don't figure this out? What are the risks? Who will incur the risks if we don't figure this out? And Dr. Kraft has been working on actually some tangible things that we might be able to do to address these questions.
That's right. So in 2023, our medical school put out, the Geisel School of Medicine at Dartmouth put out a new strategic plan. And that strategic plan included a platform on improving health equity in the school and in the communities. And I had the good fortune of working with Dr. Beth Wilson, who is the chair of the Department of Community and Family Medicine, on leading that health equity platform. So we started by doing what all good leaders do, look to everyone else who knows a lot more than we do. And we said, who across the institution, who across the college campus, the medical school, the health system is working in community engagement? And this list is just a subset of the list of groups that really put out and say, we do community engaged work. As we brought people together, we realized, you know what? We're not even on the same path. Even the terms we use, community engagement, health equity, health disparities, we're not even sharing the same vocabulary. So understanding that we were coming into the community, lots and lots of us coming into the community. We live in an area that's very rural. A town of 4,000 is a pretty good sized town for where we live. And we knew that this multitude of asks of the rural area were becoming increasingly burdensome to our community partners. How did we know? I get the phone calls. Sally, I just got the third request, just like how we opened this session, third request to get involved in another one of those Dartmouth projects. Don't you guys talk to each other? Can't you figure this out? So we knew that if we really do want to become community engaged in our clinical activities and our research activities and our service learning, we needed to decrease the amount of variation and the discoordination that our rural partners were feeling. So we got together and created the Community Engagement Coalition. Now, this is embarrassing, but I'm going to tell you that we did not include the broader community in here. We looked at each other, many of us right there on that wheel got together and we looked at each other and said, we are confused. We are discoordinated. Let's focus first on getting the academic, this wheel represents clinical, research, education. Let's get our act together, try to come up with some core common vocabulary, principles, and policies. Let's get our act together. And then what we can do is create the very simple starter set to get us on the same page and then reach out to our community to engage them. So we came together to develop principles and policies and practices to guide community engagement with the hope that by minimizing that amount of confusion and noise in the air, we can be better partners and always continuously working to advance improved health outcomes and health equity in our communities. So to get started, we chartered our work, really pulled in that scope, created a timeline, and agreed, as I said, to start with our academic community, get ourselves organized, and then work by extending an invitation for the broader community to join us. We brought together many, many folks around the system, and we looked at the evidence and reviewed our internal experiences and decided that we would create a core set of resources that's currently still under construction. And what we did is we brought folks together and sort of identified what terms are we going to use? What's our vocabulary? How will we speak about this? It's very confusing, even to the academicians, let alone what each of us are doing separately out in the community. And the activities that we identified were to create a repository of community engagement resources, as I've said, common language, principles of engagement, as Renee reviewed, and will be some common partnership practices. For example, compensating every community member who is willing to be an expert on one of our boards or one of our project teams or in one of those centers. That we want to create a way to crowdsource this work. Let's get it started. And then how can we gather information and the wisdom and knowledge from the community to curate that and vet it, and then continuously be updating this set of resources? That's under construction. Hopefully, in the next couple of months, will be unveiled. We are exploring a common community advisory board. I don't know how that's going to go. We'll see. Again, this is where we're looking to our community experts and saying, how much are we bugging you? And how much can you help us really coordinate? Can we, instead of having 5 community advisory boards, have 1 or 2? What would that community advisory board look like? What would be the agenda of those meetings? So that is currently work that is also in progress right now. And then the community health needs assessment. And I'm going to assume that everyone in this room knows what a community health needs assessment is. But if you don't, this is homework after this period. This is the richest source of information for what the community says are the health facilitators and barriers. The not-for-profit hospitals are obligated under the ACA, and the Affordable Care Act, to every 3 years at a minimum produce this one of these documents, the Community Health Needs Assessment. We need to bury that deep into the DNA of our researchers, our clinicians, our health systems, our medical schools, instead of us saying, what is the greatest need in the hospital? Reduce readmissions or decrease observed to expected mortality or decrease surgical site infections. I mean, you guys, we can all rattle off these things that are so important. Why don't we listen? We've got this document right here. It's being produced at every hospital. Let's listen and let's take those lessons, those messages, and embed those into the workings of the health system and the research agendas. So what have we learned? Of course, community engagement is important, but it can have unintended consequences. And we need to understand that sometimes by trying to do the right thing, we can cause harm. And I think that's particularly true in our small rural areas. And that institutions that are supporting either clinical operations, research, and or education initiatives really should consider how to harmonize across those academic missions so that we can create a consistent experience for those who we wish to partner with that is really rooted in shared principles and shared practices, that we can truly live partnerships that are built on respect and trust. We can get rid of the enormous cost of having that poor executive director at the food pantry when we started having to field 3 urgent questions. I want to be engaged with you. We need to really be better stewards and work to be better partners and steward the time and the resources of our community partners, and that we can discover and disseminate the best practices that are out there. So that's our work. It's truly a work in progress, and it's been just really an honor and a privilege to learn with not only our academic partners, but to have community members who are willing to roll up their sleeves and help teach us the best ways to be good partners. Thank you.
Thank you so much, Dr. Kraft and Renee. That was wonderful. We're going to welcome our next presenter. Corey, I'll let you introduce yourself and we'll get your presentation up if you can just give us a minute.
Spot. Yeah.
I don't know what happens if we unplug one of these. Let me go find someone to get that set up for you. Okay, I will be right back.
Yeah,
Would you mind?
I can
introducing
just, yeah.
yourself? Okay.
Hi, everyone. My name is Corey Howarth. I'm a family nurse practitioner at Dartmouth Health. In some other capacities, I also work with Sally and Renee, so it's great to get to present after them. My, yeah, absolutely. Yeah. Give me 1 second. Let me just get my slides up, then I can finish my introduction.
All right, in real time, we're going to mix things up. Just one moment. So we're sorting out some technical barriers. So thanks for bearing with us. We're actually going to welcome our next group of presenters, and I'm going to pull up their slide if you'll just give me a moment. And we are going to hold all questions until the end. So be thinking about those questions you want to ask our fabulous presenters today.
Good morning, everyone. So my name is Lauren Scudney. I'm a clinical psychologist in the Department of Psychiatry at Dartmouth Hitchcock Medical Center. And myself, along with my esteemed presenters, Dr. Milan Satcher, and one of our esteemed panel members, Randy Stevens. Really excited to be with you this morning to be able to talk and share on trauma-informed care of patients who are experiencing reentry from incarceration. Just a note, so this is part of a project, what we'll be presenting on today, that was funded by the Susan and Richard Levy Healthcare Incubator at Dartmouth Health and Dartmouth College, and additional research activities funded by a HRSA grant and NIH NIDA grants. So several objectives today, what we hope to accomplish with all of you this morning. So first, wanting to kind of describe various trauma experiences during incarceration and reentry. Then kind of describing how trauma reactions can impact patients and healthcare professionals as well in the context of medical care. And then finally, opportunity to kind of share and discuss trauma-informed ways that we can engage with patients and respond to trauma in medical settings.
Wonderful. Hi, everyone. So to start us off, I'm going to be discussing how to realize and recognize trauma. And so we're going to be specifically talking about the widespread impact of trauma in individuals with a history of incarceration and those that are experiencing reentry from spaces of incarceration. And then we're going to move on to talking about signs and symptoms of trauma and traumatizing aspects of incarceration and reentry. And so many of us in the room have likely heard about ACEs. So ACEs stand for Adverse Childhood Experiences. These were first described by the CDC and Kaiser, who conducted a study in the 1990s, which assessed more than 17,000 adults and found high prevalence of 10 categories of adverse childhood experiences among their participants, including physical, emotional, or sexual abuse, physical, emotional, or emotional neglect, as well as growing up in a household with challenging experiences, such as having a parent with mental illness, substance use, or incarceration. And their study found that not only were the experiences of these ACEs highly prevalent in their sample, but also have since found that it increases the risk for developing 7 of the leading causes of death in the United States. And so research has since also found that ACEs have significant biological impacts, changing the way that our physiology actually works, including the way that our hormones work, our immune systems, our gene expression. But most importantly for our talk today, research has also found that incarcerated populations in particular have a significantly high burden of experiencing ACEs, suggesting that ACEs can actually increase individuals' vulnerability to activities that are criminalized and ultimately to incarceration. And so just to orient all of us to incarceration in the United States represents 5% of the world's population, but we have 20% of the world's incarcerated population. So we incarcerate at a significantly higher level than other countries. And even beyond incarceration, we monitor and surveil individuals to a significant extent. So there are 1.9 million people that have been incarcerated, but there are 5.7 million people that are under some form of surveillance in our nation. And so during reentry, it's expected that 95% of all people who are incarcerated will ultimately return to the community, but they face a significantly high risk of mortality upon entry. So during the first 2 weeks of reentry, the risk specifically of a fatal drug overdose is 129 times greater than the general population. But there are also many other significant leading causes of death during that period, including cardiovascular disease, homicide, cancer, and suicide. But really, even beyond the physical risks, there are significant what are called collateral consequences. And so these are ways in which freedoms are restricted post-incarceration. So even having a nonviolent offense for example, let's say for drug possession, leads to lasting barriers to being able to access key social resources such as employment, housing, which restrict people's ability and limit people's ability to really create a healthy life for themselves in the community. And so individuals who experience incarceration really are at high risk of really lifelong experiences of trauma. So even before incarceration, as I stated, nearly universal experiences of adverse childhood experiences at a significantly higher level than the general population. And then during incarceration, individuals are at a higher risk of experiencing physical assault, sexual assault, and then post-release, really with our lack of a safety net for individuals as they return, high levels of stigma, significant barriers to accessing social resources, and the high health risks that they experience. There's a high risk of individuals becoming reincarcerated, really as a consequence of not experiencing sufficient support upon release. And specifically, incarceration itself has many aspects that are inherently traumatizing. And so within a carceral space, the way that our carceral settings are structured can cause insults to individuals' esteem, to their sense of self. Carceral spaces are highly punitive rather than rehabilitative. safety is directly impacted and insulted during incarceration, both on emotional levels, physical levels, as well as psychological. There's a lack of sense of or ability to really exert control and autonomy of even individuals' physical movements, not being able to even move within certain spaces, having your movement specifically defined by others. There's a significant lack of privacy as well in carceral spaces. Even things like health information can be really difficult to keep private, especially if you consider, for example, individuals when receiving medications have to wait on medication lines. And so therefore people know that you have a certain type of medical condition because there are different lines for different types of medications that are handed out. And then intimacy is also directly insulted. There are restrictions on making physical contact, even with your loved ones during visits. And so it can deeply compromise individuals' just ability to have a healthy and express healthy intimacy. And so I'm going to transition to Lauren.
And before moving to the next slide, I also want to point out, kind of keeping in mind, the different aspects of the incarceration and reentry processes that are really traumatizing, the ways in which this is also overlaps with traumatizing aspects within healthcare, the healthcare system in a medical setting. So, for example, patients experiencing physical or emotional abuse, neglect, or mistreatment from medical professionals or staff, being asked personal questions that can be embarrassing or distressing, certainly experiencing discriminatory or stigmatizing attitudes and behavior. And, and certainly the loss of kind of control or autonomy as it relates to changes in things like body functions, disruption in body function and kind of perception of those functions, and certainly the power dynamics that are inherent within the healthcare system. And so I think as healthcare professionals and related staff, it's really important for us to be able to recognize the signs and symptoms of trauma, as they're disruptive to all aspects of life, including engagement in the healthcare system, as well as interactions between providers and staff. And so now we're going to discuss kind of trauma-informed ways, that we can engage within medical settings, as well as steps that we can take to resist or kind of reduce the likelihood of re-traumatizing patients in those settings. So, trauma-informed care, and this might be a review for a number of you in this room. So trauma-informed care is an approach to service delivery, clinical practice, and communication that acknowledges the impact of trauma. And it can be implemented on, a system-wide organizational level or on a one-on-one basis with each patient. On a large scale, trauma-informed care encompasses like the setting and the environment, communications by non-clinical staff with patients, and interactions with other members of the care team. On a small scale, it's a set of guiding principles for communication that center on kind of physical and psychological safety of patients and staff, as well as empowerment. And it's essentially the how to be and what to do part of trauma-informed care within those one-on-one experiences. And this includes things like ensuring the physical and psychological safety of our patients, fostering collaboration by working together toward a common goal and making shared clinical decision-making with patients, working to foster trust and transparency and building kind of trusting relationships between patient, provider, and staff. So working to maintain boundaries, communicating in a clear, consistent style. Efforts to empower patients by facilitating their autonomy, inviting them to share their concerns, voice preferences, offer options. So they feel like they're active participants in their care. And certainly considering really important historical, cultural, and gender issues by attending to inclusivity practices, valuing patients' identity and their unique experiences, paying attention to intersecting identities and the like. And so I think ultimately, we can actively empower our patients during encounters. We can work to reduce those conditions that can activate or cause trauma and limit, which has the potential to limit, anxiety and that sense of powerlessness that can occur in medical settings. And, for those, who are in kind of clinical settings, we know that it certainly can be challenging to navigate the emotional reactions of patients. So I think that there, some really important key things to keep in mind. First, to recognize the emotional experience. Things like anger, agitation, fear, and anxiety. These are all threat responses and sometimes actually function as a secondary emotion. So, for example, a patient who's experiencing or expressing anger as a function of feeling fearful or out of control. Tuning in early, so being mindful of indicators of discontent or distress in patients, being aware of your own body movements and language, the tone of your voice. Using connection to establish support and safety. So being present focused, engaging in active listening, working to validate patients' feelings and concerns. And then finally, setting boundaries, which is important for all folks involved, prioritizing the safety of patients, providers, and staff alike. And just, very quickly, just here are a few tools that we can use to help patients regulate their emotions or behaviors in a safe way, in a safe, effective way. And these are all techniques that can be used to calm both mind and body. So they include things like relaxation, grounding, or even like transitioning patients to an alternate space. So, for example, an empty waiting room, and certainly with patients' consent. And ultimately, these tools help to both empower patients, staff, and caregivers alike. And now I'm going to turn it over to a member of our esteemed panel, Randy.
And so today we were going to have two panelists with us. Joseph has an emergency, and so he's unable to be here, but really grateful that Randy's able to be with us. And so Randy Stevens, he's Executive Director of Hope Recovery in Manchester, New Hampshire. And I know that we said that we would have questions at the end, but as part of our presentation, we also have like a section that includes some section of questions. Is that okay? Hold. Okay. 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 So then we'll just, I guess we'll wait for this section. And so we'll just ask the audience then to take note of what these questions are so that we can go through these with you. We're kind of doing a truncated version of our longer presentation. And so as part of this presentation, we have a section where we interact with you really to think through what just your reflections on your own experiences, delivering trauma-informed care or not, thinking about times in which you could have more trauma-informed interactions. And so I'll transition to Randy to do you want to just, I guess, share any thoughts that you have relevant?
Yeah. Hi, everybody. Yes, I am an executive director. So you want to talk about trauma-informed care. Dr. Kraft, you had me like in a tizzy over there with that, that walkthrough. Literally all day long, I field questions and while I'm trying to write proposals. So 6 years ago, I was incarcerated for conspiracy to sell drugs, all stemming from an addiction that I had had since I was a child. When I was 7 years old, I spent the next 7 years being heinously sexually abused by my best friend's father. And during that time, I resisted and he introduced drugs and alcohol into my life. And that became my way of coping with what was happening and the secrets that I was holding. And, fast forward another 14 or so years, I say 14, yeah, about 14 years. And I ended up at the lowest point in my life. I was completely homeless, alone, addicted, and I had a baby on the way, my youngest child, Zayla. Um, I got sober um, actually in a hospital in Portsmouth Regional Hospital in 2018. This doctor was super kind to me, was probably the only person in my life at that time who talked to me like a person, treated me like I was just anyone else, and was really happy to see me healing and getting healthy and getting well. Um, and I don't remember, who she was or her name or anything, but I remember the feeling that I felt every time she came into the room and spoke with me. Many people at that time weren't really looking me in the eye or, trying to spend time with me. I had abscesses on my arms. I was skinny and malnourished and not doing well. And so when I walked out of that hospital, I stayed sober. That was November 20th, 2018. And then 30 days later, 13 days after Zayla was born, the feds picked me up for crimes I had committed while I was in active addiction. And just to, put it in perspective, when somebody's going through that kind of experience in their life and they're trying to heal, all right, I made a decision. I'm going to use this time. I'm going to get well, and I'm going to do it to the best of my ability. And that whole time I have babies that are in random places. I have no idea if they're okay. My mother had a relapse, stopped talking to me for 3 months with my newborn baby, right? So all that while I'm trying to heal, I'm going through this, and then I'm being, shuffled around, to talk about trauma. I'm getting medical care, and I have to disclose this in front of a group of people who are also waiting for their meds. It's the only time I can see medical staff, right? So just to put it in perspective, what some of the experiences are for people like me that have been incarcerated. And I'm not saying feel bad for me. There was a lot of healing, a lot of good that came out of it. And I still to this day have to leave doctor's offices. This just happened recently with my wife. My wife couldn't understand, but for me, when the person was telling me, things like we're gonna get down to the bottom of this. We're gonna figure out why you don't understand what happened to you when you were a child. Why you don't remember getting a colonoscopy at 16 or or why you were diagnosed with Crohn's disease or any of these things. And so, I'm trying to have a conversation with a doctor, and I can't even respond. I'm choked up because she's using words that are making me uncomfortable. And I'm, 6 years sober. I have kids. I'm running a company. I'm doing all these things, and yet I can't articulate why I feel the way I feel inside. And so just putting that in perspective, and I'll let them take back over.
Thank you for sharing, Randy. And so we're just going to take some time. We have permission just to take some time to just hear from you in the audience for these first two questions. So we'd really just like to pose to you to think through how can providers, whether you're a provider or you go to a provider, how do you think that providers can better realize and recognize the needs of persons that are experiencing reentry? And then what do you wish that providers knew about your lived experiences and needs when providing care during reentry? And so if you have any responses to that. Do you have anything to add?
What I wish providers knew is that each one of us comes with a whole bunch of baggage that you know nothing about, right? We're carrying a bunch of weight, each one of us, even you in the room, right? There's tons of things that any one of you could have experienced that I have no clue what's going on in your life. But if I come and show up to our meeting with curiosity and care, it changes how I communicate with you, and it changes what you're willing to share with me as well.
I think it's important to recognize, like, depending on the field that you work in, like, you might not be aware of, patients' trauma experience. That might not be divulged in the context of the care, the treatment that you're providing. And so, but the thing to keep in mind is that with trauma-informed care, it recognizes and underscores like the ubiquitousness of trauma. Like, we all have stories, experiences that shape who we are, that shape the ways that we engage with people, especially in settings that can be, frankly, like really anxiety provoking, traumatizing. And so you don't need to know that a patient has experienced trauma or what kind of trauma or their details of their trauma to be able to act in a trauma-informed way. Because really at the core of it, it's how we connect and relate to the person in the room, the validation, the importance of like the trust, the connection. So yeah, just as folks reflecting, what are some things that come to mind, for you all when you think about, like things that you kind of wish you knew or maybe have done differently? Yeah, please.
I've worked in the jail system and the prison system for 35 years. And also, as this gentleman, I am in recovery for 45 years. One of the things that I have tried to get providers that do not have any experience with either being incarcerated or working within the jail system or having an addiction in their past is to bring somebody with them when they go into a system. I'm not talking about outside of the system, but I have found that I have better luck if I spend time in the system with people before they get out. And if I don't understand what's going on, I bring somebody with me that I can trust, that has a similar experience and can just nudge me if I start to say the wrong thing, or if I have a funny look on my face, or and what it does is it brings comfort both to the provider, but great comfort to the person that's incarcerated or about to get out.
Absolutely. Absolutely. Thank you for sharing.
I wish that every provider that I met with treated me as if I was the greatest resource in the room, right? That was just a thought I had.
So just to wrap us up, just to keep in mind, that how important engaging with folks in trauma-informed ways is, to recognize, that this approach to care leads to improvements for both patients and staff alike. So, the increased patient engagement, treatment participation, improved healthcare outcomes, and, simultaneously we see, within a system that really adheres to trauma-informed principles, increase provider wellness, job satisfaction, reduce burnout. I think there's actually simultaneously a talk that talks about healthcare wellness going on, and we recognize how important that is, that essentially all members of this system are functioning as effectively and as relatedly as we can. But ultimately to realize that, at the end of the day, trauma-informed care is about, empowerment. It's about safety on a psychological, physical, emotional levels for all involved. Thanks. Just acknowledge here.
I just want to quickly point to our acknowledgements. Transition.
And just a quick note, so we attached that in the survey. This is the QR code for the post. So I'd like to fill that out. Thank you.
Thank you so much for the flexibility of the last three presenters, and that was really powerful. Thank you for your honest presentation and your insights. I wanted to acknowledge there were some comments that came in as well. Justin and I are realizing we'll pass the mic out for the Q&A. We'll have a few minutes at the end. And we'll make sure that you can read through the comments in the chat as well at the end. I'm going to pass it to our last presenter, Corey, if you would introduce yourself to the group, and we'll hand it off to you. Thank you so much. And you come here for a second, Justin. Don't see that it is. Oh, I see. Okay, sorry. Okay. So this should. Okay.
That's okay.
Thank you for your patience.
The Zoom screen. Okay. The other things that there is just. Okay, already is extend. Other option. Dark. Aha. Okay. Okay. You said let me know when you. Sure. All right. Thank you, everyone, for your patience. Obviously, I'm not technically inclined. My name is Corey Howarth. I'm a family nurse practitioner at Dartmouth Health. And I am here today to talk to you guys about a reverse integration primary care project that my colleague, Dr. Alina Shoemaker, and I ran. Alina is not able to be here today because she is at our reverse integration primary care clinic today. And you can go ahead and click to the next one. So this really came about from an idea that her and I had when we first met years ago. We both share a passion for the substance use community and providing care there, as well as the underserved populations in rural New Hampshire. So we both practice at Dartmouth Health up in Lebanon, New Hampshire, which has for the Upper Valley a nice little bus route that connects to Lebanon, right? And really not to the surrounding towns. And we really wanted to find a way to bring primary care to people who were not able to access it at our traditional clinic. So like everyone, I think, who gets into wanting to do community-based care, we start to think about like what, right? The van, right? It's that pie in the sky, the Sprinter van. If we only had a van, we could go everywhere and we could bring care to everyone. Not quite, right? Most research shows that actually the vans, if you're not in an urban dense environment, really don't provide much benefit. So we kind of had to like give up that dream. And we started to ask ourselves, where is the most need in the community? Like the people that we want to take care of are not coming to us at our clinic for a multitude of reasons, right? Transportation, financial issues. Dartmouth is a large organization. For some groups, we kind of chew them up, churn them out, spit them out, right? And people have had a bad experience with the health system. So Alina was doing some work with a Moms in Recovery program at one of our satellite sites, which is River Mill. It's a SUD treatment facility that's part of Dartmouth, but it's actually run by the Department of Psychiatry and not by the medical school. So we were able to get some grant funding through a grant called the Burbank Grant. And we were able to convince them to let us try for 6 months to take what we do at our standalone clinic and bring that over to the folks at Rivermill and provide basic primary care services there, right? But there had to be kind of some ground rules. And the ground rules were Alina and I could not take on and become PCP for this entire population, right? There's just like, there's two of us. It's not going to happen. If you want to advance the slide, you can. So what we agreed to do is anyone who had a PCP listed, we would facilitate and communicate with that PCP, even if they were outside of the DH system. And if someone did not have a PCP listed, we would help facilitate getting them connected with a PCP. Right. Like all best laid plans, they fall apart a little bit. And I think lots of patients have endeared themselves to us and we have taken them on as PCP as we've gotten to know them. So this slide just demonstrates just basically a little bit of what we aim to do. It was a really slow launch, right? We had about 6 months of funding. I feel like it took me about 6 months to get people to trust me. Right here, I am this new face. I'm in this random room over at Rivermill. The psychiatrists are like, "Hey, you should go see this guy." Right? He's kind of nice. You might really like him. And it probably took them really coaxing people 4 or 5 times for people to want to come back. Traditionally in primary care, what do? People come in, they want to get their physical, they have a sense of like what their family history is, the things that they want to look out for. This does not happen, I feel like, in reverse integration primary care. We're meeting people where they're at, right? And I always say the biggest preventative care offering I can provide is whatever they want that day, right? And it's kind of like the basic things that we all learn about in med school or nursing school, right? Like, what's the goal of the first visit? Get them back for the second visit. Because if they don't come back, I can't help them. So initially, we were seeing a lot of wound care, a lot of xylazine wounds, and just tending to that, right? Almost very transactional. Like, what can I get out of this person? Like, what's this guy going to do for me? But by providing that, I was finding people are coming back more often, right? A little bit more about this clinic. It's also on the Lebanon bus route. So you would think, well, if they can get to Rivermill, they can get to our other clinic at Heater Road. Not quite, right? Financially, people have to prioritize where they're going to go, and they're prioritizing going to their SUD treatment, right? And so from a primary care lens, we're doing them a disservice by then saying, oh, we'll hop the bus and go up the street to another appointment, right? It's literally 1/2 mile away. It's just not doable. It's just not doable. So if we're there, they can get all the services they need when they come in for their other therapy. Dr. Shoemaker is there every Monday. I'm there every Thursday. So we keep consistent hours so that people know when they can come see us. The other important thing was people don't need an appointment, right? That's the other barrier. If they want an appointment, awesome. I'll see you at 10:30. If you want to walk in at 10:45 because you've got a burning concern, I'll also see you at 10:45. I can average anywhere from 8 patients to 20 patients in a 4-hour period, depending on what's going on that day and what the weather's like outside. And yeah, I think to get back to the fundamentals of like, what do we do in primary care? I think we listen to people. I think the best advice I ever got that served me really, really well for this clinic was from an old fire chief who told me, sometimes like you just got to keep your door open and your mouth shut. And I think it's really great advice. And I feel like that's what I do every day here is I just welcome people into my exam room and ask them, what can I do for you today? And they tell me. In my other clinic, it's like written in the comments. I know what they're here for. But taking a broader approach, I think just lets people tell me what they need. After 4 or 5 visits, I can start to sneak in what I think they need. Right, a little bit here and there. So after 6 months, we were able to show that we had a moderate degree of success. And I have a really, really great team at my traditional clinic. And so my medical director and the chair of my department allowed both Dr. Shoemaker and I to continue this work. And we had to make it sustainable. I think that's the other part that people don't, it's like the not sexy part of this work, right? Is like, okay, well, how do you keep this going? Like, we got to bring in money because no one's paying for my time or Dr. Shoemaker's time. So we had to make the decision early on, like, we have to treat everyone the same. So are we going to bill or not bill? Right? That is the question. And we went with bill because it just did not see a way to keep this financially viable. And essentially, like, we're coming into an at-risk population who have probably been told a million times, we're here for you, right? Like, we're not going to go anywhere. And we took that really seriously. And we didn't feel like we could make that honest offer if we weren't able to build, bring in revenue, and continue to be allowed to go, right? Otherwise, it'd probably die the death of most other unfunded projects. Great idea, but we got to keep the lights on. We have a great team at Rivermill who helps any of the uninsured folks that come in find insurance and can even work on getting some back payment. So that has really helped. The other part of our pitch was, obviously, I'm stepping away from a 4-hour block of clinical time at my traditional clinic. Alina is stepping away for 8-hour block. And so what happens to that commitment we made to our department? Well, we were able to work together and make it so that the revenue that we get from our River Mill clinic flows back to our traditional clinic, right? The other thing that did for us is it got us the same nursing services for triage that we have at our traditional clinic, right? So all of these patients that we are seeing at our reverse integration clinic benefit from the larger services we have at our other clinic. So yeah, that really helped. And I just lost my train of thought. Yeah, so we have also a couple other ground rules that we established with the psychiatry providers here because we want to play nice in the sandbox, and we really, really appreciated being allowed to have this room, right? So we have one exam room. It's your basic exam room that you'd see in every primary care office, right? We've got your table there, and then we have your glorified flashlights and magnifying glasses on the wall, right? Like the tools of primary care. And we agreed that we would not touch any controlled substances, right? So that would stay completely within the realm of psychiatry because they were already helping with the SUD. They were already managing people's bipolar. So we were not going to manage mental health. We wanted to have a clear distinction between what we were providing and what we were not providing. And that has worked out really well. We're able to just say, hey, great, you're going to see Dr. Hibke next, and he's going to take care of all of that. But hey, I can help you with the primary care piece. We focused on a couple of benchmark endeavors to really show that we were making a difference. And if you want to go ahead to the next slide. And the big ones were trying to improve screening, right? So to get people tested for HIV, Hep C, STI testing, get their colonoscopy, right? Get their mammogram, get their Pap, all these things. Like, these are the big ticket preventative care items that we were interested in once we built a relationship with people. And I think that we showed almost a 70% uptake in being able to test the full population after 6 months that came in. The one thing that we were not successful with was vaccine delivery. I think for a multitude of reasons, we really wanted to be able to provide vaccines. We didn't have a large fridge. It did not meet the same criteria that the larger hospital has. So that's one area that we've not been able to be successful with, but are continuing to push to get large storage for vaccines, right? Because a vaccine deferred is a vaccine declined, right? People are not coming back for it. But for the screening, people are coming all the time. And I said we're about a half mile from the main hospital. We're probably about quarter mile from a small community hospital that their lab is attached to our medical record. And it's been relatively easy to get people to even walk up there. I've walked people personally, been like, hey, if you've got time at lunch, like I got an hour for lunch, let's walk up to Alice Peck Day together. I could show you right where the lab is. We can walk back, right? Some people just need that buddy system too, of like that person to go with them, and it's so much less daunting. So that has helped immensely to get people the care that they need. We're now going to be branching out to in this building. It's this large old mill building, right? Because there's not a million of those up in northern New England. That's been repurposed. You know, the River Mill's in there. There's, I think, Irving Oil or something has their headquarters, but we also have West Central Behavioral Health, which is a mental health provider who is looking to partner with us as well. Literally, if like we just have this giant rectangle that's a hallway, right? On the far left end, we have Rivermill. Like in the middle, we have the door in, and over on the right-hand side, we have West Central Behavioral Health. So it's like all in one spot, right? And they've asked us to come over. They have a little bit of space and would like us to do the same thing. So this is awesome. We're growing. People are excited about this. It's also really hard to do. Again, there's two of us, right? And we also have got these expectations for our other traditional clinic. So while we appreciate the desire for expansion, one of the unanticipated things that we're trying to work through is how can we provide services for everyone who's coming into both doors more centrally, right? Because, and it makes sense. The folks over at the SUD treatment center do not want random people walking in the door, right? Because we want to be extremely, extremely careful and protective of the people who are there for the reasons they're there. And the same thing with the folks over at West Central. But we can't be running between doors all the time. Thankfully, everyone's kind of on the same page of this is the right care to give. And right now we're entertaining conversations about, is there a way to bring people in through the back doors, right? So that we can stay in one place and have the patients come to us. It would be wonderful if there was, you know, vacant office space in between those two, and we could just get that vacant office space, but there isn't. So those are the things that are coming. And I want to leave time open for questions, comments.
Oh, just a large picture just in there. Thank you all so much for your flexibility with our tech woes today. I do apologize. And thank you again for the flexibility of our panelists. You are excellent. So we have 5 minutes left here for Q&A. I do see we have quite a few questions coming through in the Zoom as well. So I'm going to say we could take 3 questions. I'm going to start with one from the Zoom for our panelists here. And I am going to take the last one that came in. Let's see here, as you're thinking of your questions. This one comes in from Cheryl. Will you please discuss the prevalence of traumatic brain injury in our incarcerated populations and its implications and impact on the life choices and mental health? If one of the panelists wouldn't mind, this is only microphone connected to the Zoom. If someone would be able to answer that. And then as you're doing that, I can walk over to the next person who has a question. If you could raise your hand in the audience, and I'll bring a microphone over.
Hi, Cheryl. That is an excellent question. And that's actually an area of active research right now, since they're in general, getting any prevalence data for incarcerated populations can be difficult. But there are researchers right now that are specifically focused on TBI because of the significant implications that it has for, executive function and impulse control and therefore behavior. Um, Anecdotally, I can say I'm a clinical provider. I do addiction medicine, practice addiction medicine with patients who are experiencing reentry, and TBI is, in my opinion, not uncommon, either from events that have occurred prior to incarceration or events that occurred during incarceration. And so, definitely grateful that this is an area of active research.
Can you hear me now? This question's for Randy. I'm curious, how much, if you see the use of peer support, amongst incarcerated folks, both in the prison system and outside. So individuals who have been incarcerated who are helping others, supporting others, either in, like peer support groups in the prison, peer support groups in the community, or any other types of peer support within the incarcerated community.
You want me to repeat that question? Yeah. Well, that's going to be tough. So basically what you're asking is whether I have seen peer support actively in incarcerated settings. Yes.
And in the community.
And in the community. So the answer is yes. So my profession by trade is a peer support specialist. That's where I came in. So I was living in the halfway house in Manchester, the federal halfway house, and I walked across the street and got a job at the mental health center as a peer support specialist. It was a way for me to get into the field without education or anything like that.
When you say peer support specialist, do you mean mental health peer support specialist?
So I mean both.
Or substance?
Both recovery coach, which is the substance use side.
Recovery coach is
In New Hampshire,
substance
it's the
use.
CRSW, right? That's the state certification. And
Yep.
there's a CPSS, which is the mental health side of
Right.
peer support. And so, yes, so I was dually certified. I am dually certified. Yes.
Yeah.
And so I train all of my peers at my RCO well, they received the training from the state because now we've developed in New Hampshire, it's a certified peer support specialist training that the state provides. It's through DHHS. So yeah.
Yeah. Is there any such thing as a certified incarceration peer support specialist or
We
certification?
don't have that yet, but I have been advocating for that because I believe it's it's a whole nother section of peer support, and there's a whole nother language that you have to be able to speak in a way that you have to be able to connect with these people that you won't find in any other setting. So
Thank you.
you're welcome. Just to further answer your question, though, I was a peer mentor in a residential drug and alcohol program in the feds for 14 months. So there is that is a tool that the feds and other programs, like even in Stratford County, that they leverage peer support as a way to help facilitate healing for people.
There are two states, Georgia and Pennsylvania, that have started forensic peer support. Sorry, I was just going to say there are two states, and there are a few others that are working on it, but particularly Georgia and Pennsylvania have started what they're calling forensic peer supports, which I don't really like the term, but forensic peer supports, which the name of that sounds weird to me, but it's individuals with a lived experience of incarceration that support people during the reentry process, but it's not yet widespread across the US.
Do we have one more question in the audience? And I'll try to take one more online. I know that we are headed into lunch and let's see if we have one more question online we can get to.
Yes, this question is also from Cheryl and it's for Sally and Renee. Do we assess the level of satisfaction of our communities feel the engagement in the community health program design and implementation? Do you actively seek input and feedback from the community? If yes, to either, would you describe how this is done?
That is the $1 million question. How do we measure in a standardized, reliable, and valid way the quality and value of that engagement? Um, uh, we are not doing very well right now. We are doing the best that we can, but I'm going to refer you to two sources. One is the REST survey, REST. Research evaluation. Yeah, I'm sorry. Dr. Melody Goodman is the originator of that survey. My socks are blown off when I saw that survey. It consists of 9 questions. Each question has 2 parts. How well do you do it? And how often do you do it? Isn't that clever? Because we do a lot of things well once, right? But we don't sustain good practices often. So that survey, the brief rest, REST survey, is where we're going to really start to lean in and try to use that on a regular basis. There's another survey, the QP Core. And I apologize, I'm blanking on, I'm not doing a good job coming up with the, someone here will know what that stands for. QPCOR. That was actually developed by a Dartmouth researcher, Dr. Karen Fortuna, who works a lot with PCOR, the organization PCOR. That's another relatively brief survey that I would suggest taking a look at. But those 2 surveys, that community engagement repository of resources, those will be the 2 surveys that we're going to try to infuse in all of our work across our rural communities. It's a great question.
Thank you so much for these rich presentations, for the sincerity and thoughtfulness of our presenters. I'm sure we all have a lot to process and bring into our own work following the session. So let's give another big round of applause for our presenters today. Thank you so much. And we'll be transitioning right now into lunch. So enjoy the rest of your time at the summit. Thank you.
I'm on a mission.
Yeah, you know, like, and we couldn't tell you which three farms have a dog land. Yeah, yeah. Because we have a lot of land. One is. Yeah. It's very much like.
Forever. Get the kids out.
Well, thankfully, friends is on 60, but I was getting ready to get into all the things. He likes to go to forest today. He lives in them. It's very sick. And sorry, I'm just for that. I don't think the hair stuff on my face. Organize it for the next presenter. Like
And it's like.
Well, I went
Thank you,
into
Justin.
the
Justin
screen
drove it.
displays and I saw they were already extended, so I was like, oh, okay, so if I do this, it should work. But you never, yeah, that's fine. Presented.
Of the insurance. Yeah.